Hello there. My name is Brandon Dessecker. I'm one of the fourth-year surgery residents. We'll be talking about surgical breast disease today. So, brief outline, we'll be talking about anatomy and physiology first, then we'll move on to pertinent things in history and physical. Next, we'll move on to benign breast pathology, and then we'll move on to the more malignant breast pathology following that. So, the anatomy, the breast is really fed by many peripheral arteries. It's not really fed by any named breast arteries. However, it does get tributaries from the internal thoracic, intercostals, thoracoacromial arteries, as well as the lateral thoracic artery. Your big ones are going to be your internal thoracic, your intercostals, and that lateral thoracic. Your venous drainage comes from Batson's plexus. This is the name of really any sort of venous structure that doesn't have valves, which is abnormal for most venous structures. The importance with that is that whenever you get metastases, you can see bony metastases if it does metastasize through the blood. Typically, it goes to the bones straight from the breast, which is odd if you think about lymphatic drainage, right? Speaking of lymphatics, breast is drained 97%, about 97% by the axillary nodal system, and then the remaining 2-3% is drained through the internal mammary lymph node. So when you're asking your history and physical, when you're asking your history, you need to pay important attention to menarche, parity, menopause, prior hormone replacement therapy, and family history. You also have to make note of previous breast biopsies, as well as the pathology of those previous breast biopsies or any previous breast carcinoma. Screening, typically you're going to start with a mammogram every 2 years after age 40. The recommendations change a lot depending on what organization you look at. However, you really need to look at just the USPSTF's recommendations. They're the important ones. Some people say you should get yearly mammograms. And one of the important things is, regardless of which organization you look at, if a first-degree relative has had breast cancer, you need to do a screening mammogram 10 years before the first age of diagnosis in that first-degree relative. So if they got breast cancer at 30, you need to start screening at 20. As far as your workup goes, it depends on age. If the patient presents with a symptomatic mass, less than 40, you're going to start out with an ultrasound. Just because of that dense breast tissue, you're not going to be able to see it very well on mammogram. You can do a core needle biopsy from this, and then if your ultrasound's indeterminate, you can move on to mammogram. If they're greater than 40, you should start out with a mammogram first, and then you can do an ultrasound and a core needle biopsy to further characterize that mass. And if you're getting indeterminate results on these mammograms, then you need to do an excisional biopsy. If you have a cyst, you should aspirate it. If it is bloody, you need to take it out. If it clears and it comes back, you need to take it out. Or if it's a complex cyst, you also need to do true surgical excisional biopsy of it. Moving on to benign breast diseases, this is going to be mastitis, galactoseals, galactorrhea, gynecomastia, and fibrocystic breast disease are going to be your main ones. Introductal papillomas can also be found, and that's going to be typically with nipple discharge. And then you can also see fibroadenomas, especially in younger patients. As far as mastitis is concerned, people are going to come in complaining of painful local erythema and fevers. They're going to have a history of recent breastfeeding. Risk factors would be like smoking, nipple piercings, anything that has any sort of trauma to the breast. And then pathophysiology is typically going to be due to infection with skin flora. Your workup is going to be clinical, and your treatment is going to be a continuation of the breastfeeding, and then antibiotics, specifically covering gram-positive organisms like your staph and your streps. Staph is going to be the most common, and if they're not breastfeeding, you should consider malignant etiology, and then if they don't respond to antibiotics, you should also consider a malignant source. Patients can present with breast abscesses. They present similarly with mastitis, however, they're going to have a fluctuant mass on physical exam. This may drain. Sometimes it can even drain through the nipples, however, typically it drains through the skin. This is going to be from infection with skin flora. Same as mastitis, however, you're going to get abscess formation in these patients. Your workup typically is going to be clinical. However, you can use an ultrasound, which is going to show a complex cystic structure. And then you can also send TBCs as well as wound cultures. Your treatment is going to be incision and drainage, avoidance of breastfeeding if they are currently lactating, and then antibiotics is covered for the same organisms as the prior mastitis type patients. As far as the treatment, some places now are saying more currently that you should do a aspiration with a needle and treatment with antibiotics. However, I think for your test purposes, it's still going to be incision and drainage is going to be the treatment. As far as galactoseals are concerned, these type of patients are typically going to come in. They're going to have cessation of breastfeeding. It's going to be painful mass. It's going to be smooth, and it's going to be very mobile and a cystic feeling mass. Pathophysiology is typically going to be a ductal obstruction, and then you get that localized milk collection. Your workup is going to be clinical. However, you can also use an ultrasound to diagnose this. It's typically going to be a simple cystic type structure. If it's small, even if it's large, really, you should probably aspirate this first. However, if that doesn't work, then you need to do an incision and drainage on it. Galactorrhea. This is one of the more common med student topics that you get with breasts, especially with the medical aspect of it. So these patients typically are going to have milk let down from the breast. It's going to be painless. Sometimes they can have amenorrhea depending on the cause. So your pathophysiology is going to be anything that increases your prolactin or decreases dopamine. So increased prolactin is one, typically going to be from pregnancy. Drugs are going to be others, so oral contraceptive medications, metoclopramide, most of the antipsychotics are all antidopaminergics, so that's really what's going to cause that as well. And then the classic pituitary microadenoma is also the more common tested one, and that causes decreased dopamine letdown from the pituitary gland. They typically have that bitemporal hemianopsia, so they lose their peripherals, lateral vision on both eyes. Your workup is going to be clinical initially. If they have an elevated prolactin level, then you may want to start investigating other sources, and then typically you move on to an MRI of the brain after that elevated prolactin level. If it's from the drugs, stop it. However, if they do have one of those microadenomas, then you're going to have to typically go with your bromocriptine, cabergoline are the two main ones. Bromocriptine is probably the more common one. And then if they do have a microadenoma that doesn't respond to this, then you need to actually do a transsphenoidal resection of it. Gynecomastia is also one of the more common things that you'll see. On history, you're going to note the typical drugs. They have that mnemonic in step 1, first aid. Some drugs cause awesome knockers. Spironolactone, marijuana, cimetidine, alcohol, and ketoconazole. Typically, it's going to be from increased estrogenic influence. Your workup is going to be clinical. And as far as treatment is concerned, most regress. However, sometimes they need cosmetic. Fibrocystic breast disease is one of the other very, very common breast diseases. Typically, you're going to see these patients, they're going to be young, they're going to have mastalgia, which is pain of the breast. They can have a yellow-brown discharge from the nipple, and then they have nodular breasts. This is typically cyclic, depending on where they're at in their cycle, and it's caused by increased and changes in hormonal influence. Your workup is going to be, depending on their age, ultrasound if they're young, mammogram if they're old, so greater than 30, greater than 40. Typically 40 is going to be the number. However, some places say 30. If they're older than that, then you start out with a mammogram and a core biopsy. If they're younger than that, typically you start out with an ultrasound and a core biopsy. So if they have atypical ductal or lobular hyperplasia, you're going to resect these patients. However, if not, you're just going to monitor them. Typically, you're going to treat them with like a tight-fitting bra, or avoidance of caffeine is also one of the other big ones. Patients with intraductal papillomas present typically with bloody nipple discharge. You're going to localize it with your physical exam to which duct is causing it. It's a benign growth. And then your workup is typically going to be a contrast ductogram with needle localization. So you identify what duct it is, insert a very thin wire into it, and then shoot contrast through there to identify the papilloma. And then you should do a subareolar resection of just that involved duct and the papilloma. Patients with fibroadenomas are typically going to be young women. It's going to be a painless, firm, well-circumscribed, rubbery mass. This is a benign growth. However, it can enlarge with hormonal influences as well. Your workup is going to be very similar to any sort of palpable breast mass, right? So if they're younger than 40, start with your ultrasound. If they're older than 40, start with your mammogram. And then if you have ultrasound findings, mammogram findings, your history and physical are consistent with this, and you have a core needle biopsy of it that says it's a fibroadenoma, then you can monitor these patients if they're younger than 40. However, if they're older than 40, this is something that needs to be. As far as malignant breast disease is concerned, we'll talk about a couple of different things. Some of them don't really fit. Some of them aren't exactly malignant per se, but we'll talk about that a little more. So ductal carcinoma in situ, these are going to be malignant cells of the ductal epithelium. However, they're not going to invade that basement membrane. These are pre-malignant lesions. They need to be resected, and they need to receive X-ray therapy in some patients. That's a little bit more outside your realm. However, patients with ductal carcinoma in situ should get resection without a doubt. As far as LCIS is concerned, this is not necessarily a pre-malignant pathology. However, it's a marker for development of further breast cancer. So about 40 to 50% get cancer in either breast, not necessarily just the one with LCIS. However, you're never going to feel these on exam. You're never going to see them on mammogram. So if you see this on a pathologic biopsy, it means that your biopsy missed the spot that you were trying to get initially with your biopsy. So if you have LCIS on a biopsy and nothing else, but you did the biopsy for a reason, so that reason is probably something else around it that you missed with the biopsy. So typically you need to do an excisional biopsy after you get this pathology, just to look for any other breast cancer around the area. So your treatment is one of three things. Typically it's going to be tamoxifen. However, you can just observe these patients carefully, and in some circumstances you can even offer them bilateral mastectomies because of the high rate of breast cancer development in these patients. As far as breast cancer in itself is concerned, this is going to be more of the ductal and lobular carcinomas that you're going to see. These are going to be the invasive ones that go through that basement membrane. So the bone is going to be the most common site of metastasis, and that's because of those Baston's plexus that we talked about a little bit earlier. High-risk patients are going to have either two primary relatives with bilateral or premenopausal breast cancer, or they're going to be BRCA positive. Those patients are at very high risk for developing breast cancer. Patients at moderate risk for developing it are people who have had prior breast cancer and radiation exposure to the area. And then low risk are going to be those typical history things that you ask: the early menarche, the late menopause, nulliparity, or prior hormone replacement therapy. Whenever you excise breast cancer, there are certain hormones that you want to check for. You can even do this on your core needle biopsies. You're going to look for estrogen and progesterone receptors, as well as HER2/neu receptors. So if they're estrogen or progesterone receptor positive, then you're going to give them hormone therapy, and that's going to decrease their rate of recurrence by about 50%. If they have HER2 new, then that's typically somebody that you can give like trastuzumab to, and then there's even one newer one that's pertuzumab. It's called Perjeta, and they're even using all three of these in addition to other chemos in neoadjuvant settings in patients who have much higher stages and like much higher stage breast cancer. As far as ductal carcinoma is concerned, that's going to be the most common. That's 85% of them. And then there's many, many subclasses. However, your treatment is going to be a lumpectomy, and then you're going to have to do a sentinel lymph node biopsy. If she does not have palpable nodes, if the patient does have palpable lymph nodes, then they need an axillary lymph node dissection. So the difference is you have to consider the site and the lymph nodes a little bit separate. So if somebody has a very big mass and it needs excised, then typically you're going to either do neoadjuvant or you're going to do a mastectomy. Alright, so that's what it is for the actual local area. And then as far as the nodes are concerned, it's dependent on a couple of things. If you can feel them, if they're palpable, or if they've been biopsied prior and found to have cancer, then you need to do an axillary lymph node dissection and clean out that whole area. If they do not have either of those, then you're going to do a sentinel lymph node biopsy. So you can do a mastectomy with a sentinel lymph node biopsy. You can do a lumpectomy with a sentinel lymph node biopsy. You can do a mastectomy with an axillary lymph node dissection, which is called your modified radical mastectomy. Or you can do a lumpectomy with an axillary lymph node dissection. So it's all different depending on the lymph nodes and depending on the site. If it's a small tumor, you may be able to get away with breast conserving therapy. However, if they have positive lymph nodes, then you're going to need to do the axillary lymph node dissection. And then if you do any sort of breast conserving therapy, like the lumpectomies and things like that, then you need to follow this with breast radiation therapy, and that is to help decrease the rate of recurrence, specifically local recurrence in these patients. As far as lobular carcinoma is concerned, it's treated the exact same way as ductal carcinoma. However, it's a more aggressive variant, and fortunately, it's a less common variant as well. They have a high risk of multifocal disease and a high risk of bilateral disease as well. Phalloides tumors, these are technically sarcomas, so they are not in the same realm as the breast cancers, the other breast cancers, the ductal and the lobular carcinomas. Phalloides tumors are sarcomas, so they spread through the blood. So typically, you do not need to do any sort of lymph node dissection. However, you do need to excise these because 10% of them can be malignant. They're often very large as well. Of recurrence. Inflammatory breast cancer, this is typically going to be those patients who come in with a big red erythematous breast. They have those Porter orange changes, and that's typically from the dermal lymphatic invasion of a breast cancer. This can be any sort of a ductal or lobular carcinoma, and it's just categorized by the clinical suspicion. This is going to be T4 disease. Typically it's stage 4, however, some can be very high stage 3s. And those patients are typically going to get staged fully with CT and LFTs, and then will most likely go on to neoadjuvant chemotherapy. And then typically they get a modified radical mastectomy and subsequently get adjuvant chemotherapy and radiation. Most of these patients aren't going to make it to surgical resection. Unfortunately, most of them pass away secondary to their disease before they are candidates. Alrighty, thank you. And if you have any questions, feel free to email me. Thank you.